Cancer is a complex disease or set of disease that's caused by both genes and environment. And I think we made enough progress over the last few years to understand more and more of the genetic causation of cancer and the role of gene-environment interaction. So about maybe 10 to 20% of cancer has some important genetic component to it, and the vast majority is environmental, but even within that, there is some gene-environment interaction.
Jan Lowry. I'm a cancer epidemiologist and associate professor at the University of Colorado School of Public Health. It's important for individuals to know about their genetic risk for cancer because their risk, as compared to the average population, is quite high. And it's useful because there are things we can do to help these individuals reduce their risk for cancer. Such things as cancer screening. So for hereditary breast and ovarian cancer and for hereditary colon cancer, individuals who are at risk for these types of syndromes are recommended to begin cancer screening at much younger ages than the average person in the population and to screen more frequently than others. There's also other options in terms of chemoprevention that can reduce one's risk of cancer, or hereditary breast cancer, for example. And there's also more extreme measures that these individuals can take to reduce their risk by having prophylactic surgeries. So the two most common forms of hereditary cancer are hereditary breast and ovarian cancer, which accounts for about 5% of breast cancer and about 15% of ovarian cancers. And the other is Lynch syndrome, which is the most common form of hereditary colorectal cancer. We have genetic tests now that can determine whether individuals have genetic predisposition to both of these syndromes. For women who carry mutations responsible for hereditary breast and ovarian cancer, their risks are quite high. For breast cancer, their risk can be as high, lifetime risk can be as high as 80%, and that's compared to a 12% risk in the average population. And for ovarian cancer, the risk can be as high as 40%. And again, that's compared to the average risk population of less than 2%. So individuals that have Lynch syndrome, again, the most common form of hereditary cancer, their lifetime risk for developing colorectal cancer can be as high as 80%, compared to an average risk in the population of only 5%. So it's also important to note that individuals that have and families that have Lynch syndrome have increased risk for other cancers besides colorectal cancer. They have high risk for developing endometrial cancer, perhaps as high as 40%, and increased risks for other cancers such as stomach cancer, ovarian cancer, urinary tract cancer, and kidney cancer.
In terms of using genetics to prevent cancer, today, from a public health perspective, there is a group of conditions. There are genetic conditions leading to increased risk of either breast or ovarian or colorectal cancer and a few other cancers for which there are interventions that currently work and evidence-based guidelines around them. And so there is a set of these genes that together maybe account for a substantial and not insignificant number of the US population. So specifically, genes related to BRCA1 and 2 that put women and men also at increased risk of breast cancer and ovarian cancer in women. There are a number of genes related to increased risk of hereditary colorectal cancer, the Lynch syndrome genes, and also related to that are other types of cancer like endometrial cancer. So together, these two types of conditions maybe account for about 1 million plus people in the US population right now. So it's a small number, but not an insignificant number. I think we're continually improving our ability to diagnose and refer. And basically, it's a little bit more better on the hereditary breast and ovarian cancer. The recommendation for action came from the US Preventive Services Task Force in 2005, the first time the gene initially was discovered in 1994. So we have almost 20 plus year history. And then every now and then a few celebrities like Angelina Jolie sort of tell their stories, and that increases the awareness in the general population about the risk of hereditary breast and ovarian cancer. On the Lynch syndrome side, I think we're doing a little bit less good on that. It's relatively unknown. It leads to early onset colorectal cancer. I think the recommendations for action came a bit later than the breast cancer one. Our own EGAP working group at CDC has made recommendation in 2009. I would say the majority of cases of Lynch syndrome in the population are not diagnosed. I don't have an exact number. On the breast cancer side, that percentage has gone up steadily, and we're trying to do surveillance and figure what that number looks like.
We believe that the proportion of individuals in the population that carry one of these mutations, either for hereditary breast, ovarian, or Lynch syndrome, is rather small, less than 1%. But again, these individuals that have these mutations have very significant cancer risks. Unfortunately, we also believe that less than 10% of these individuals who carry these mutations are aware that they have these within their families. The most important way in which we identify these families who are carriers of these mutations is by taking adequate family history, and generally this should occur in primary care. So questions that we really need to be asking are, is information about cancers within the family, the types of cancer that family members have, and importantly, the age of diagnoses within these families. Early age of diagnosis within these families of these specific types of cancer is an indicator that this family might be at increased risk for one of these hereditary cancer syndromes. So that's one reason that we don't identify these individuals. The other is just in general in primary care, among primary care providers, there is a general lack of knowledge of these hereditary cancer syndromes, what families are at risk, and what their needs are in terms of screening or referral for cancer genetics services.
I don't think we're doing that well necessarily. I don't have the latest numbers, but since 2009, there has been a steady, slow, but sure uptake of these recommendations. There is a nationwide Lynch syndrome screening network that is trying to implement those recommendations. My sort of best guess at this point, and we're analyzing some health claims data at this point to look at these numbers, is that very few of the new cases of colon cancer are tested for Lynch syndrome in the U.S. population. And remember, we have about 140 to 150,000 new cases of colon cancer in the U.S. So at least in that pool, there should be somewhere between 3,000 and 5,000 cases of Lynch syndrome. And if you diagnose them, you can cascade to their relatives, first-degree relatives who have a increased risk. So you could be targeting at least 10 to 15,000 people who may have Lynch syndrome, who deserve the colonoscopies and early interventions, and then they don't even know it. So I think we have some room to grow on the Lynch syndrome side. On the hereditary breast and ovarian cancer, the numbers are a little bit better. I think the way to do the screening usually starts with women who are at increased risk because of strong family history or ethnic background, and about 5 to 10% of women fall under that category. And the task force recommended that these women should get genetic counseling first, and then testing if appropriate, and then the right interventions to go along with that.
There's several things that we can do, and one of the things we can do in primary care is to integrate family history questions within the electronic health record to make sure that every patient that comes in for a visit is asked about their family history, and importantly, ask about the questions that are important for identifying persons at risk, again, including information on types of cancer in the family, the age of diagnosis, and the relationship of the family member to the individual.
The world of public health is very much into cancer control, and if you take the examples of colorectal cancer and breast cancer and ovarian cancer, there are a set of activities that are done by public health, and each state has a cancer division. They even have cancer registries with mandated reporting of all cancers in each state. So I think many states have started a number of activities to increase the level of awareness about these hereditary conditions. And depending on the expertise and fundings and resources, they've worked with the healthcare providers in their community and general educational campaigns to the general public. What's good with the availability of the cancer registries is that you can interact with reporting, the cancer reporting from the cancer centers. And for example, in the case of Lynch syndrome, you can figure out and do a bidirectional reporting between the cancer registry at the state level as well as the reporting entity in the state, because you can figure out how many cases of colorectal cancer have been tested for Lynch syndrome. I think the recommendation, which I did not state, is that all new cases of colon cancer should be tested for Lynch syndrome, because once you find a Lynch syndrome in a case of colon cancer, you can cascade to the relatives, the first-degree relatives who have a much higher increased risk of colon cancer than the general population. And if they have Lynch syndrome, they need to start screening earlier than the usual 50 years sort of recommended age cutoff for the general population, and will be in the 20s with more frequent screening. So depending, I mean, each state is doing it slightly differently. The Division of Cancer Control at CDC is funding a few of them to do activities that fall in three general areas: surveillance to figure out what's going on, education of the providers and the general population, as well as working on policy efforts to increase awareness and coverage for saving lives from these conditions.
Another approach to identifying individuals at risk is by identifying individuals who already have cancer, and because they might have been diagnosed at a young age, might also be at risk for having a hereditary syndrome. To do this, we can use public health infrastructure such as cancer registries that collect information on all cancers diagnosed within a given population. Information that we collect through these registries includes age of diagnosis, and by using this information, the registries become a valuable resource for identifying families that might be at risk. Here in Colorado, we did do a pilot study to see whether we could use cancer registries to deliver an educational outreach to individuals at risk for hereditary colon cancer. We identified patients that met certain criteria based on their age and certain histologic cell types of their colon cancer. And we used the registry to deliver a message to these individuals about hereditary colon cancer, Lynch syndrome specifically, who's at risk, what the implications are for the family and for the individual in terms of screening. This was one of the first projects in the country to investigate whether a registry could be used for this purpose, and it was very successful. Overall, we found that physicians were very supportive of the registry delivering this information directly to their patients, and they were very supportive of the materials that we had put together for their patients as well. We also surveyed the patients at the time that we contacted them to ask about how they felt about being contacted directly from a cancer registry. And what we found was that patients were not angry, they were not mad. In fact, most of them wanted more information about hereditary cancer. So in that regard, we feel that this project provided strong evidence that registries can be used in this capacity to deliver these messages. And in public health, I think our role is to make sure that these patients, these individuals within the population who are newly insured, are aware of the genetic services that they are eligible for. And at the same time, that we educate the providers who are caring for these individuals to let them know who is at risk, what services are available, and how these patients can benefit from having genetic testing. One of the challenges to improving access to genetic services is figuring out how to integrate the delivery of these services within primary care and public health agencies. And on a national level, there is now great interest in trying to develop models to do this very thing so that we are not increasing disparities with respect to genetics. As new tests become available, we can assure that everyone who has access to healthcare is getting access to these services, and we're using a systems approach to make sure that these can be implemented into primary care settings.
I think we have a much longer way to go in terms of raising the level of national awareness around these hereditary cancers. We keep a very active horizon scanning of public health genomics, sort of where the genomic science is moving and what are the leading edge of applications. Obviously, as we do this and we display that in our weekly update on our website, we're discovering more and more that the world of cancer does provide the leading edge for all public health genomics in general. That's why we're spending time today to talk about it. More than 50% of the mature applications in genomics that are ready for clinical practice and public health interventions are in cancer. So of course there are other areas, but in cancer itself, there is other than the two conditions that I've talked about, there is a number of hereditary cancer syndromes, but also the whole notion of using the whole genome and what people call genetic stratification of risk to try to fine-tune screening recommendations. So this is an area very active right now. I mean, the high-risk genes are one thing. 5 to 10% of cancer is due to high-risk genes, but the rest, the 95%, there is a lot of other genes that increase your risk on a much smaller scale. And if you put them together, we call it the polygenic, the polygenes, so to speak. You can stratify women and men according to cancer risk and try to tailor the recommendation for screening and interventions based on the combination of what their age and their genetic profiles. This is an active area of research. Of course, the biggest area right now for cancer treatment is the cancer genome itself, the mutations of the cancer. And this is part of the President Precision Medicine Initiative, trying to figure out how to use the cancer genome itself for targeting driver mutations with therapeutic drugs that are more targeted based on not the histology or the stage of the cancer, but more on what kind of genetic manifestations and gene mutations that the tumor has. That's a very active area, and many academic centers are involved in it. Now, how and when will it reach a level of maturity for sort of a population-wide approach? I predict over the next 5 to 10 years, there could be a leading edge for that. So to summarize, there is two areas: the germline, i.e. our own genetic predispositions, from the high-risk genes to the intermediate risk genes, and then there is the genes of the tumors and how they can modulate treatments as well as interventions. There are other areas in the genome of the cancers, including the gene expression profiles, epigenetics, proteomics, areas, some of it is already in clinical practice, like gene expression profiles in breast cancer to predict recurrence. And so this is a very vibrant and emerging area of science that has leading edge of applications both in the clinical domain and eventually for population health.
I also think the role of public health workforce is to keep genetics in perspective. So as more and more tests come out and the population becomes more and more informed, perhaps by looking at the internet, we need to be prepared in public health to provide context to these findings. We know, for example, for cancer, 70% of cancers we believe are sporadic, so not due to these genetic forces.